also getting insulin and also penicillin was given 1 dose before delivery because of the positive GBS status. Okay. Okay, APGAR score was 8 at 1 minute and 9 at 5 minutes. So she has a good APGAR score. Cord blood pH was 7.058. And this is a little bit on the acidotic side. Usually 7 is okay. Birth weight was 2.8 kilograms. And she was given blow by oxygen and in the delivery room after birth and was sent to newborn nursery. The baby developed hypoglycemia soon after birth, and after that, the baby was transferred to the NICU. On physical examination on arrival in the NICU, the Ballard score was 36 weeks AGA, and weight was 2.7 kilograms, length was 47 centimeters, and FOC was 32.5. All the parameters look okay, except the head size is a little bit smaller, which can happen in infantile-diabetic mothers. Vital signs, the temperature was normal, pulse was 130, resps were 70 per minute, and the blood pressures were within normal range, and the capillary refill time was about 3 to 4 seconds on the sternal area. Okay. On general examination, the baby was tachypnic, but not in acute distress, not significant retractions, but little bit of tachypnea. Head was normal. There were writings of the sutures. She had HENT examination showed that the baby had hypertrichosis of pinna, and also pupil was equal, palate was intact, and respirations are bilaterally normal, and pupils are reactive to normal. Neck was supple, and chest was, baby had mild crackles, but no significant retraction, and the breathing rate was a little bit elevated. Cardiovascular system, the baby has S1 and S2 murmur, and 2/6 ejection systolic murmur along the lower sternal border. Abdomen was soft, bowel sounds were heard, and there was no hepatosplenomegaly and no distension. GU was normal, female genitalia, anus was patent and midline. CNS, the baby was a little bit jittery, and primitive reflexes are all present, but the baby was mild hypotonia. And this is the characteristic of babies who are born to mothers with diabetes. And extremities were no deformities and no hip clicks. Back was no sacral dimple and had hyperpigmentation at the lower back. Okay. Pertinent labs. CBC showed mild leukocytosis. There were increased bands and nucleated RBCs. IT ratio was 0.31, and there was no polycythemia. Hematocrit was 56.3%. And the infant diabetic mothers do have leukocytosis usually, and they may have increased bands and nucleated RBCs that will give a higher IT ratio. And also another association, hematological association of poorly controlled diabetes is infant diabetic mothers polycythemia, but this baby was not polycythemic. His hematocrit, her hematocrit was 56.3%. And usually we call polycythemia, especially for the students, if the hematocrit, central hematocrit is 65% or more. In blood gases, she had mild respiratory alkalosis because she was a little bit tachypnic, so she was blowing off the carbon dioxide. In chemistry, she had hyponatremia, hypochloremia, hypocalcemia, and hypoglycemia, all the metabolic things which were on the lower side. Hyponatremia is because they retain a lot of fluid. And similarly, there can be hypocalcemia, which is a common association, and hypoglycemia, a common association of infant diabetic mother. So our resident who was doing that, she followed the blood glucose levels, and it started with 28 milligrams per DL and slightly increasing. And towards the end, it was 45 milligrams. And it varied. And during this time period, this baby was receiving intravenous glucose. Chest X-ray, baby had bilateral hazy lung field, and this we thought was due to retained lung fluid, and which is a common association in infant diabetic mothers. They don't clear their lungs as quickly as baby whose mothers have no diabetes. Echocardiogram, since there was murmur, we saw dilated PFO and minimal left to right shunting. So our impression on admission into the NICU was prematurity, because the Ballard score was 36 weeks. An infant of diabetic mother, hypoglycemia, electrolyte imbalance, respiratory distress due to non-clearance of the fetal lung fluid. And since she had GBS positive, they also put suspected sepsis. So this is the hospital course. Number one is always after examination, we look at the healthcare maintenance. And that means intravenous fluids or feeding and so on. Initially was started on IV fluids using 10% glucose and formula, and then was introduced and then changed to Infamil AR because of feeding intolerance, which is also a common consequence of poorly controlled diabetic pregnancies. Baby was started on breastfeeding because we always promote breastfeeding with a lot of benefits. And then in the metabolic system, she had severe hypoglycemia. A mini bolus of D10% glucose was given at the rate of 16 cc per minute, and the total volume baby was receiving about 2 cc's per kilogram. Then she was started on maintenance D10 in water, and using up to the calculation was done on the basis of cc's per kilogram. On first day, usually that's what we use, about 65 to 70 cc's per kilogram. Glucose strength was gradually increased. We started with the 10% glucose. We had to go up to 18% of glucose because of the sustained hypoglycemia. Glucose infusion rate was, which we also call it a GIR, was high, 15 milligrams per kilogram per minute. At that time, in those days, we were also using steroids, and she was given as recommended by the endocrinologist for 7 days for sustained hypoglycemia. In spite of these measures, hypoglycemia does not resolve until day 14. After that, the baby did fine on oral feedings. Respiratory system, the baby had, because of the tachypnea, was put on Vapotherm, getting oxygen through the nose, humidified oxygen. After that, she did well. And this respiratory difficulty in these babies is for two reasons. There is a delay in fetal lung clearance. And do you know how much is the fetal lung fluid? Anybody, residents, students? Hello?
Yes, sir. Those who want to respond, please raise your hand. If anyone,
younger, junior people should answer. Anybody? It's quite a bit of fluid. It's about 50 to 80 cc's per kilogram of the baby. And this fluid is in the interstitial space. Cardiovascular system shared a murmur, but no murmur was found at the time of discharge. And cardiovascular conditions are also common in infant of diabetic mothers, but this baby did fine. Hematological system, baby had mild jaundice, but jaundice is another complication, but this baby was lucky, and maximum bilirubin was 4.2 milligram per DL and did not require phototherapy or any. GI system, the baby had difficulty in coordinating suck and swallow probe. And this is quite common in infant of diabetic mothers. This is due to the presence of amino acid, which impact the sucking and swallowing method. Sometimes we had to put G tubes and IV maintenance. Also, some people thicken the IV formula and they use rice cereals. Infectious diseases, because of Anemia, increased IT ratio. She was started on ampicillin and gentamicin. Antibiotics were discontinued after 48 hours of negative blood cultures. And this is what is being done more commonly. And there is some restriction for the prolonged use of antibiotics with negative blood cultures. Neurodevelopmentally, the baby failed hearing screen in the left ear, ABR, and was scheduled as an outpatient. There was abnormality of suck and swallow that was resolved eventually. Dismissal plan, baby was discharged on day of life 21. Post-conception age at that time was 39 weeks by Ballard score. Weight at discharge was 3.1 kilogram, and recommended diet was 1.5 to 2 ounces of 20 calorie per ounce formula every 3 hours, and then breastfeeding was also offered. So this is the picture of the baby. I hope you can see it. And what we see starting from the head, the baby has chubby cheeks, and also lying down, like the hands upwards, and like legs also apart. And you can see there's thickened or big upper and lower extremities. And some people used to call this as a Buddha baby. And it looked like Buddha and face and hypertrichosis of pinnae. So now I will start with my introduction. After we finish the case presentation, hypoglycemia in the neonates used to be a very common problem in the 70s, and over most of the research on hypoglycemia and management was done in 70 to 80 decade. Glucose homeostasis in the fetus and neonate is developmentally regulated by, and determination of glucose concentration is dependent on the type of tissue and method used for analysis. We have to see where we are drawing the blood from. Complexity of glucose metabolism makes it difficult to define precisely what is normal and abnormal glucose in the preterm and term. Now this is better defined now, and nowadays any baby who has a blood sugar level less than 40 is considered hypoglycemic, and then followed along, and it follows more, then it treated accordingly. And right now in our center, on day 1, blood sugar should be 40 milligram per deciliter. Day 2, we take it as a 50, and day 3, 60 or above milligram per deciliter. Okay. So now, a little bit about my objectives, historical aspects of this condition, glucose homeostasis, method of glucose analysis, definition of hypoglycemia, neonatal conditions associated with hypoglycemia, clinical signs and symptoms, hypoglycemic mechanism of central nervous system injury and sequelae, screening of hypoglycemia, recommendations for treatment, congenital hyperinsulinemia, which is a non-IDM cases, but it is also an autosomal recessive disorder. It's more common in the Asian countries and more common in Middle Eastern countries. Then there is medical-legal implications and summary and conclusion. Okay, wait a second. I don't know how to get rid of that. Blood glucose analysis in adults was introduced in 1911, so many years ago. Newborn blood glucose analysis was established just recently in 1920, and hypoglycemia defined in newborns definition was in 1937, and clinical signs symptoms of hypoglycemia correlation was established in the year 1950. Neuronal necrosis secondary to severe hypoglycemia was recognized in adults due to hypoglycemic coma, and that was used for many conditions such as syphilis and so on. High-risk factors such as toxemia, maternal diabetes associated with neuronal hypoglycemia was established in 1954 to 1959. Definition, anticipation, prevention, and management was established from 1963 to 1994. I remember when I started working with babies in the 1970s, it took a while for this definition to be established. Initially, we really did not know what the definition of blood sugar level is. So then during that time period, there were consensus of meeting on definition, laboratory diagnosis, therapy, and long-term outcome of neuronal hypoglycemia at the national level. And the last recorded meeting, which I see, is 1997 in Japan. So after that, there were several other consensus meetings. But now I think through this that we have established what is the normal glucose level. So glucose homeostasis in the perinatal period, glucose homeostasis. Glucose is delivered by the mother to the fetus across the placenta and is stored in the liver as glycogen for immediate energy. And fetal glycogen deposits occur in the first trimester. A significant amount not present until the third trimester. So there is an increased risk of hypoglycemia in preterm babies. Fetus is also capable of gluconeogenesis, neogenolysis, and intrauterine growth restriction will activate this and deplete the glycogen stores. Okay. Other substrates for energy are lactate, glutamine, glycerol, which can be converted in the fetal liver to glucose via gluconeogenesis. Fetus is also capable of metabolic machinery necessary to build, break down, and store glucose. So this activity in utero prepares the fetus for neonatal existence. Glucose is delivered by the mother to the fetus across the placenta. I think I already, I think I talked about that. We talked about the other substrates. And so this is the mother, and it's a diagram, and she gives glucose directly through the umbilical vein into the baby, and then it's stored in the liver as glycogen and would be used as for energy. So glucose homeostasis also, the mother, if the baby is hypoglycemic, there's the production of lactate, glutamate, glycerol, which is deposited into the baby's liver, and which then gives back to glucose, and this is called as a gluconeogenesis. Factors affecting the blood glucose values. CNS depends upon the glucose as a metabolic substrate. Direct measurement of glucose in the neuronal tissue will be ideal, but clinically not feasible at the bedside at this time. Concentration of glucose in the blood has been clinically used as a glucose concentration in the brain also. Whole blood glucose levels are 15% less than serum glucose. So when you do the blood glucose determination, whole blood glucose, it will be 15% less than if you do analysis from serum glucose. Venous specimens are 10% less than arterial or capillary specimens. So venous specimen is better, ideal choice. Arterial and capillary ideal choice is arterial blood sampling or the capillary sampling. WBCs, RBCs, platelets, and bacteria increase glucose consumption, so we may see hypoglycemia as an association. Blood sugar be collected on ice and assayed within 30 minutes of collection to get proper results. Any questions up to that, especially to the junior residents and students? Any question to me? I've already sent this presentation to Dr. Vikram and Dr. Nazir. So you can request them to give that to you too, if you need it. So what are the commonly used methods for glucose concentration? Glucose analyzers use an ionic selective electrode technology, and it's called as the bedside method, and it was first established in Lahore Children's Hospital, and now this is used quite commonly. And this is one of our nurses, Kathy Ray. I worked with her for a long time, and now she's also retired just like me. And this is the laboratory method. It's called as a hexokinase method. Serum glucose is both methods provided similar glucose values above 40 milligram per deciliter. Below 40, this is not very, very accurate. Commonly used methods continued. Now a lot of research has been done in non-invasive techniques and is being investigated and perfected. And now many centers use that continuous glucose monitoring with a non-invasive technique. This condition of non-invasive method to monitor glucose will be very, very similar to oxygen saturation and transcutaneous bilirubin monitoring. Okay. So definition, there is no clear consensus existed for hypoglycemia in the newborn nurseries, neonatal intensive care units, or in the courtrooms. And so there was no consensus. Now recently, for the last 2 years, they do have a consensus based upon clinical signs, which are very subjective, and common signs for all other neonatal conditions, such as hypocalcemia, hyponatremia, and other issues. Numerical values as returned by blood serum glucose are better. In our nursery, currently hypoglycemia is defined as blood serum glucose levels less than 40 on day 1, serum blood glucose level less than 50 considered after that, and less than 60 on the 4th day thereafter. Okay. Any questions up to here? Clear? So mechanism and conditions associated with hypoglycemia. It is primary failure to produce and or store glucose and glycogen. And so it is seen in prematurity because glycogen deposition does not occur till they are in advanced gestation age. Depletion of glycogen stores and excessive utilization occurs in intrauterine growth restriction, post-maturity, sepsis, hypothermia, renal hemorrhage, hypoxic ischemic encephalopathy, polycythemia, and there's one more I should add, congestive heart failure. Any questions up to here? Okay. Also, now we also see other mechanism and conditions associated with hypoglycemia. Number 3 is hyperinsulinemia, and this is seen in infant diabetic mother. It also can be seen in pregnancy-induced glucose intolerance, large for gestation age infants delivered to obese women, maybe non-diabetic, but they are have an increased BMI. And so this is quite common, and it has been published in neo reviews. Congenital hyperinsulinemia, which used to be called as residuoblastosis, and now it is called persistent hypoglycemia and hyperinsulinemia of pregnancy. And it could be also due to iatrogenic. And how does iatrogenic cause? What is the reason for iatrogenic cause? How does that happen? Anybody? Students, residents, fellows, nurses? If the mother is given very high concentration of glucose during labor, it will transfer to the baby and produce hypoglycemia. Also, if the mother has been given beta mimetics, these medications are used before to stop labor, but now they are not used, so that could also has been eliminated. And it also has been seen in severe blood glucose alloimmunization, RH diseases. They say that they almost behave like infant diabetic mother, and that should be followed. Then there are inherited diseases, inborn errors of carbohydrate, protein, and lipid metabolism, and malformation syndromes, Beckwith-Wiedemann syndrome, and congenital hypopituitarism. So I'm sure some of you must have heard the Beckwith-Wiedemann syndrome, and these are really large for gestation age babies, almost look like infant diabetic mother, and they do have hypoglycemia. They have other cardiac anomalies also, and omphalocele is also seen. They have a big tongue and big, the umbilical cord is like a big rope. So it is increased in growth of different areas, and congenital hypopituitarism also. Other condition, family history of hypoglycemia is also associated with this condition. And so factors increasing the susceptibility to hypoglycemic injury. Neonate is more vulnerable due to inability of independent enteral nutrition. They cannot go to the refrigerator to get milk, inadequate glycogen stores and substrates, and immaturity of the regulatory enzyme systems, and poor cerebral blood flow regulation. All of these will cause a susceptibility of hypoglycemic injury to the brain. Okay, the sites of neurological injury. This is the main concern with IDMs. There is, due to hypoglycemia, occurs in cerebral cortex, thinning of the occipital region, and that's why visual problems are seen in these babies with severe hypoglycemia. And also this could be diagnosed by MRI, also dentate, gyrus, hippocampus, caudate nucleus. So these are things where, regions where we can find out. Mechanism of injury to the brain. Usually, when there is hypoglycemia, there is an amino acid which is called as glutamate, and which functions as transmitters. And I'm sure Many of you know, and this is the same mechanism in hypoxic ischemic encephalopathy, and glutamate is released with hypoxia. And then the NMD receptor for glutamate is also coupled to calcium ion channel. And this increases the influx of calcium into the neuronal cells, and there is prolonged stimulation leads to accumulation of calcium to toxic levels, causing neuronal death or neonate death. Okay, so this is the mechanism of injury. There is hypoglycemia, particularly very low blood sugars, less than, I should say, 30 or 40s, and it releases glutamate release, amino acid and neurotransmitters. And then it is coupled with calcium. So the calcium is coupled with the glutamate. It enters the neuronal cell and causes apoptosis or cell death. And this is the mechanism of injury to the brain. And, I had the opportunity to see some untreated mothers, babies being born with microcephaly and long-term problems. So cerebral glucose delivery is adequate to meet the glucose consumption within the brain. Glucose delivery depends upon the concentration of glucose in the blood and at the rate of blood flow to the brain. If the glucose concentration falls, and compensatory increase in blood flow to the brain occurs, and that may produce to interventricular hemorrhage, especially in premature babies. So neurological manifestations of neonatal hypoglycemia, and there is in CNS response, and then there is an autonomic nervous system response. In CNS response, you see apnea and tachypnea, cyanosis, eye rolling, and seizures, jitteriness, tremors, irritability, and excessive crying and shrill crying, lethargy, tachycardia, and poor feeding. The autonomic nervous system response is diaphoresis, just as you see in adults who are getting high doses of insulin, and diaphoresis, the very first sign you see when you have a low blood sugar. There is instability of blood pressure. There could be bradycardia. There's increased tracheobronchial secretions, gastric paresis, and that's why these babies have difficulty sucking and swallowing, and hypothermia. Okay. So hypoglycemic seizures are associated with profound hypoglycemic plasma level less than 25, and even maybe lower than that. The ones I've seen had very low blood sugar. Seizures due to hypoglycemia have a very, very poor prognosis as compared to hypocalcemia, as compared to hyponatremia, and as compared to hypernatremia. So we should be very careful and that is the reason we follow glucose levels in these babies. EEG abnormal patterns are seen in parieto-occipital region with the occipital lobe epilepsy, and that's where the center is. So it's injury in that area leads to visual disturbances. Neurological sequelae due to profound hypoglycemia. Microcephaly, I have seen these babies, lower psychomotor scores, poor deficit, mental retardation, and visual impairment. During my work, I did see all of these babies because we had a lot of babies with hypoglycemia due to the Hispanic population we served. Auditory and visual evoked potentials have been reported to be abnormal, moderate hypoglycemia, but a repeat study did not confirm this. So we can make this diagnosis of profound hypoglycemia by doing neuroimaging. So in the acute phase, we see cerebral edema and patchy hypoechogenic areas, and follow-up images done between 1 to 72 hours. There will be parenchymal hypodensities, particularly seen in the occipital lobe, that is the site for brain injury. Level of glucose in these conditions was only 7 milligram per DL, and advanced imaging technology may be more helpful. So neurological sequelae in profound hypoglycemia. There were 17 patients. They had neuroimaging findings were 100% correct. Occipital lobe involvement was seen in 82%. Dilatation of brain lateral ventricle was 41%, and parietal lobe involvement 29%. Other brain parts involvement was seen in 12%, babies with severe hypoglycemia. Neurological sequelae of profound hypoglycemia. Seizures as a presenting symptom was seen with severe hypoglycemia in 70% of the cases. This was the period when we did not try to screen hypoglycemia. So at that time, it was common. Babies with small heads, poor motor and psychomotor development was seen in 65%. Visual impairment was seen in 41%, and microcephaly was seen in 35%. Any questions up to these? So blood glucose level, median, they say, is which was seen had dropped down to 77 milligram per DL, very low. The range in these babies was the range of blood sugar was 2 to 26 milligram per DL. And postnatal time when hypoglycemia was detected, median age was 48 hours. And range was 1 to 277. So it's a later hypoglycemia for that day. And immediate does not, but if persists, it can cause problems. So screening for hypoglycemia. Who should not be screened? And this is the rule American Academy of Pediatrics. This was done when I was in training. We used to screen every baby for hypoglycemia. So cut the costs, and American Academy of Pediatrics came with this ruling. So healthy term neonates with no risk factors, so should not be screened. Who should be monitored? All unwell infants and at-risk infants, maternal conditions, diabetes, beta blockers, oral hypoglycemic agents, and intrapartum high percentage of glucose administration to the mother. Okay. Other screening should be done always in neonatal conditions. Preterm babies, IUGR babies, HIE babies, because that causes also hypothermia and infection. It has a strong association with hypoglycemia. And over here, I should also say congenital heart failure due to. And also the other conditions, polycythemia, as I mentioned, hematocrit greater than, central hematocrit greater than 65. Now we go even up to 70 or above. Also, who are receiving parenteral nutrition, large for gestation age babies are also associated with that. And infant of obese mothers, and they also almost behave like mothers with very high BMI. And obvious syndromes and dysmorphic babies babies with congenital heart failure or congenital heart condition. So when should blood sugars be obtained? Soon after admission in all unwell infants or neonates, sorry, before feeding in well infants. It should be checked before feedings in well infants if you are going to screen for it. When required investigations are, when further investigations are required, symptomatic hypoglycemia in a healthy and well-grown term infant, hypoglycemia with seizures or lethargy, persistent or recurrent hypoglycemia, hypoglycemia screening requiring greater than 10 milligram per kilogram per minute. This is called as a glucose infusion rate, GIR, hypoglycemia with congenital abnormalities such as Beckwith syndrome, and also some of the CNS injuries, also seen in babies with cleft lip, cleft palate. Prevention, initiation of early breastfeeding in stable babies is recommended. Formula is an alternative. Use of plain glucose water is not preferred. Nowadays, you're using glucose gel, and that could be given orally, and it has benefits. It works well in some centers. In preterm babies, infusion of appropriate requirement of intravenous glucose therapy promptly after admission to the NICU. So that's why we don't see very many babies with prolonged hypoglycemia without these two methods, early feedings and infusion of glucose. IUGR infants may be hypoglycemic in utero, so immediate screening and therapy is prudent for these babies when you check the blood sugar immediately. Asymptomatic and other health. Oral feedings is the treatment of choice, or breastfeeding immediately. We should not delay the oral feedings in babies anymore, both for premature and also term babies. Follow-up of glucose in about 30 minutes after the treatment. If hypoglycemia persists, then we should start IV therapy and using the minimum bolus to correct it. Symptomatic or preterm neonates, 10% glucose. This is the mini bolus. We give them 10% glucose, 2 ml per kilogram over 1 ml per minute. In continuous infusion, we can give them about 6 to 8 milligram per kilogram per minute. Follow-up glucose every 30 minutes to 1 hour until stable and hypoglycemia persists. Give bolus again, 10% glucose, 2 ml per kilogram, and increase continuous infusion of glucose by 2.2 milligram per kilogram per minute. If hypoglycemia persists despite administration of 12 to 15 milligrams per kilogram per minute of glucose, hydrocortisone could be used in those days, but now they use other anti-hypoglycemic agents. And if further investigation is needed, we should consult with a pediatric endocrinologist. This is how you calculate the glucose infusion rate. You give percentage of glucose solution times 10 times the rate of infusion over 60 per kilogram. There are some simpler methods also, but this is, and there is the long method, which I used to remember, but this is the method most of the people are using now. Okay. And to refresh our minds and vision, I put this picture of these red and flowers and green leaves and purple flowers. This is gardening, as you know, is my hobby. Okay, so now we'll do the congenital hyperinsulinemia, CHI or PHHI, which is also a cause of severe persistent hypoglycemia. For decades was considered as mesothelioblastosis. Biochemically, it is inappropriate and unregulated insulin secretions from the pancreas. It is characterized by very high levels of insulin, C-peptide, as compared to blood glucose. So that's why we do all these other tests, considered to be genetic disorder, mainly autosomal recessive, and more commonly in the Middle Eastern countries, I think because of increased incidence of congenital first cousin marriages. So clinical presentation of hyperinsulinemia is present in the early neonatal period, non-specific presentation as lethargy, specific presentation occurs as seizures with a very low level, and they're always macrosomic. Hypoglycemia, this due to high insulin level. Hypoglycemia is persistent, profound, and recurrent. So we have to protect these babies. High levels of glucose infusion rates are required to maintain a normal glycemic range. In preterm infants, it may be associated with hypertrophic cardiomyopathy. And hyperinsulinemia can be transient, as seen in IDM, Beckwith-Wiedemann syndrome, and IUGR. So GI problems associated with hyperinsulinemia, foregut dysmotility and gastroesophageal reflux, poor sucking, retching, vomiting, and intestinal dilatation. Nasogastric tube feeding or gastrostomy may be required. This may delay normal feeding, taste, and orality. So when we are doing that, we should also give small volume feedings. Okay. Also, what are the laboratory and therapeutic diagnosis of CHI? We should do hyperinsulinemic level, hypoketotic, hypofatty acidemia, and hypoglycemia. These are combined together. Insulin growth factors, binding protein, IGF-BP1 is low. Glucocorticoid activity is blunted. Steroid therapy does not improve hypoglycemia in such cases. Positive glycemic response to glucagon and octreotide can occur. Medical management, these are some of the octreotide infusion of very high glucose, sometimes as high as 20 milligram per kilogram per minute may be required. Diazoxide and chlorothiazide are also used for hypoglycemia. This was an incidental finding. It was used to lower the blood pressure, and then they also saw the blood sugar also went up. Nifedipine, glucagon, octreotide, and the last is the surgical therapy, pancreatectomy, partial or total, to prevent CNS injury. Medico-legal aspect of hypoglycemia. Severe hypoglycemia, when untreated, can lead to neurological sequelae, and poor neurological outcome may result in medico-legal actions. So medico-legal actions are not related to non-availability of high technology in a hospital, but due to substandard clinical practice. And this is very important to know. Lack of recognition and screening of high-risk infants, failure to confirm the low blood glucose values, and not obtaining a serum glucose because this is more accurate. Poor documentation of prompt administration of appropriate therapy with subsequent resolution of clinical signs, and a lack of further investigation and consultation where clinical signs fail to resolve once plasma glucose is corrected. Infant's clinical condition at the time of hypoglycemia. This is proper documentation. Plasma glucose concentration should be documented. Nature of treatment, infusion glucose, milligram per kilogram per minute. Nature and timing of clinical response to therapy. And this is also in this area, Whipple's triad. You find the diagnosis, you look at the symptoms, find the diagnosis, treat the level and then decrease your symptoms. Plasma glucose at recurrence of symptoms and plasma glucose measurement. Plasma glucose. Okay. Practice points. I hope you can tell. Evaluation of neuronal hypoglycemia status requires an accurate and precise measurement. Reagent strips as alone are unsuitable, but now better strips are available. Routine monitoring of glucose concentration, healthy and appropriate, is not required. High-risk infants are at increased risk of hypoglycemia. They may require careful monitoring and management, and underlying metabolic or endocrine disorder should be considered when hypoglycemia is profound, persistent, prolonged, occurs in lower-risk infants. The possibility of litigation warrants clear documentation of both clinical, biochemical, and therapeutic response, which is called the Whipple's trial. Okay, development of laboratory standard glucose analyzation and non-invasive techniques, refinement of thresholds of safe blood glucose concentration, definition of relationship between blood glucose and alternative fuels and cerebral blood flow changes, mechanism of hypoglycemic neuronal injury. And this is my bibliography. And this is a class of students and residents. When I was working with them, I miss them all. And this is Dr. Zishan. She helped me to present this conference. And these are some of the other doctors. And this is Dr. Alapate. Some of you may know, she's our cardiologist. And this is Dr. Alishan. He's now a big neurologist in Columbus, Ohio. And okay, good. So thank you for your participation and attention for this talk. And I think this talk is very important because it may lead to permanent brain damage and developmental disease. So any questions? I think I went right, finished at time. It's now almost 10 o'clock. We started at 9. Any question? Doctor, yes. Go ahead.
Thank you so much, sir, for a very much nice presentation. And so we have a few questions from our participants. Sir, here the one question is, so can you hear me?
Yes, I can.
Right, sir. The one question is, which neurodevelopment problem occurs in case of persistent hypoglycemia?
Yes, I think I showed a slide on that. Initially, microcephaly is an important part. And then also conditions associated with microcephaly, poor development, delayed in milestones, and so on. And now they're confirming that injury with MRIs and so on.
Right, sir. But the second question is, first we increase the rate or GIR in case of persistent hypoglycemia?
I think we should work with GIR because that will be more constant. Some babies may not tolerate a very high fluid infusion rate. So I would work with increasing the GIR.
Right, sir. Thank you, sir. So third question is, does every baby with hypoglycemia prone to develop the neurological injuries?
Not every baby. Remember, I showed you the slide with severe and prolonged hypoglycemia are the cases at risk. So we should prevent that, check that early, treat them early, and protect their brain.
So, sir, prolonged, it means more than 7 weeks, as we say, in case of the persistent hypoglycemia.
What was that again? I couldn't. You said something.
Sure.
So
I'm saying the duration should be more than 7 days with severe persistent hypoglycemia. They are more prone to develop the
probably, maybe not even that. Maybe 3 days or so. I have seen that. So, but it is persistent and prolonged hypoglycemia is an issue. Okay.
Okay. So another question is, when to start the drugs pharmacotherapy like diazoxide in case of the persistent hypoglycemia?
At that time, I would get a recommendation of endocrinologists if you have. I think you do have pediatric endocrinologists in Karachi, right?
So actually, we have endocrinologists, but mostly in the remote area, like in Infusion. Most of time we haven't found.
I think they still check with a little bit higher level. You know that they should check along with you in the institutions, your hospital, Aga Khan Hospital, teaching hospitals. So then they go forward and get their recommendation. That's what I would do.
Okay,
right?
sir. All right, sir. So another question is there any role of prophylactic glucose gel to prevent the hypoglycemia?
Yeah, I think we had been using that. Glucose gel could be used, and there is a protocol. If you are interested, I can get the protocol for you, and you can keep it in your centers, and you can use it, and it does work okay.
Okay. So second is same question. Can we give dextrose gel instead of IV glucose simultaneously in case of hypoglycemia?
What it's saying? Intravenous glucose?
Can we give dextrose gel instead of IV glucose?
You can start with dextrose gel. That's what we had. But I'll send you the protocol. It has a good protocol, which I have not used it lately. So I will send it to you definitely.
Right. So another question is, does there any role of hydrocortisone nowadays in case of transient or persistent hypoglycemia?
Yeah, I think I'm not very clear on that. That was our first choice of treatment, but now I think with diazoxide and other things happening and using higher concentration of glucose, I have not seen hydrocortisone being given recommendation by our endocrinologist. I can check that out for you too. I can talk to them and they will let me know.
Right.
Okay.
Right. Another question: which method of screening glucose is reliable? Bedside glucometer or laboratory? As per your presentation, blood glucose is 15% less than plasma. So most of you check bedside glucose check. So therefore, value at bedside might be false. So sir,
yes.
Question, which one is best?
I think, of course, number one, now they are going, if you have a question, going on serum glucose, send the glucose to the lab, especially if you have a severe problem, and let them do it, and then send the result to you. And I think this study was done in Lahore Children's Hospital, and they had good results with their bedside glucose determination. So, but I'll check these things out for you and send the recommendation. Okay.
Okay. So another question is, if we recommended the feed to the baby in case of hypoglycemia, so how much GIR we can calculate from the mother feed?
I think the mother feed, I'm not familiar, but main thing is initiating of feedings. Feeding initiates, it decreases the insulin, it regulates the insulin. So I would give the feeding as much as that baby will tolerate. If it is very premature baby, you can give it like 20 cc's per kilogram per day divided into 8 feedings. But feeding even small volume is very, very important. And using the mother's milk is the best thing because the baby gets immunological health and other thing. And even coating the baby's mouth with mother's breast milk, they do say that there is benefit of that. So mother's milk, I'm always for that and counsel the mothers and bring the milk.
So it's very difficult to calculate, I think, GIR from mother feed. For example, if we give the 20 ml feed per kg to any newborns every 2 hourly or 3 hourly. So even though it was my query also, so in that case, can we calculate approximately GIR?
The GIR with feeding? Yeah, I think I have to go back and look at it, and I'll let you know about these things.
Okay, excellent. So
Okay.
another question from Dr. Naveed. He's asking, 10% dextrose water boluses repeatedly is discouraged as it might surge insulin. What is your expert advice when to give it?
Yeah, I think what it is, if the blood sugar is very low, less than 25 milligrams or so, then you can use, and you have already fed the baby, or then you can use mini bolus. And mini bolus is 2 cc's per kilogram. And again, in order to prevent the upsurge, you give it slowly over 1 cc per minute. And so that the baby, and at the same time, feeding helps. Feeding cuts down the upsurge in insulin level. So I would always recommend you to do bolus feeding, and also small amount of feeding. Best thing is to use mother's milk because it has a lot of good things in it. And you can even paint the oral cavity with colostrum, and then whatever you have. Okay.
So, in case of, we can give bolus when the level is less than 25?
Less than 25. That's what the protocol in our center is.
So it is of day first of life, or we can also use the same value on day
later
2?
on also you can use it too. If it is not coming up, you can repeat that, right?
Okay, right, sir. And sir, for day 2, sir, in case it was a day first, level should be more than 25 to prevent from the bolus. But in case of day 2, can we consider 25, less than 25 for bolus, or we consider level is 35?
Yeah, around 35. Some people say on day 1 now, the new levels are 40 milligram per dl. On day 1, that's the level of glucose you should try to attain, then go to 50 and then to 60 milligram per dl. So whatever method works for you, but I think I will send you some protocols. And we had worked with our endocrinologist. Maybe you can adapt that in your hospital if your seniors would allow you to.
Sure, sir. So another question is, any role of anticonvulsant in case of seizures due to the hypoglycemia? Apart from the glucose, is there any role of anticonvulsant?
Yeah, I think you have to control the seizure because, as you know, one seizure then can cause further damage to the brain. So I would also give, most of the time they will respond to glucose infusion. And then the other thing they say is now you can start, especially in premature babies, intravenous proteins that will inhibit the development of hypoglycemia. And we use intravenous protein on day 1 using 1 in the range of 1 to 3 milligrams per kilogram per day. And then that is also the advantage of putting some milk in the baby's mouth, and particularly the mother's milk. Okay.
So, what about sir, like levetiracetam or phenobarbital? Can we use, or can we give in case of seizures?
What did you say? I couldn't catch that.
Sir, can we use, apart from like as you mentioned, we can use proteins, IV proteins?
Yeah, intravenous protein. Yeah.
And that, here is, yes, sir. Can we use levetiracetam like anticonvulsant or phenobarbital in case of the fits due to secondary?
Yeah, if the seizures are continuous, you have to control the seizure first. You have to benzodiazepine, or there are new anti-seizure medications. Maybe.
Right. And sir, and so
maybe
how many boluses we can repeat of in case of like less than 25% sugar? How many maximum boluses we can repeat?
You can use about 2 to 3 times. We do have a protocol. I'll send that to you.
Right,
but mainly protect the baby's brain.
Right, sir. Another question from Dr. Naveed. He's saying, what about use of glucose gel to avoid admission to NICU? And what is the best weaning method of IV dextrose and slow introduction of milk feed?
Mhm. Slow introduction, milk feedings, it depends upon the baby and clinical status. Usually you can use in very tiny babies 10 cc's per kilogram and divide that into 8 feedings every 3 hours. It roughly comes to 1 cc per feeding in a very tiny baby. And then you gradually increase it. And we usually increase it if the baby is tolerating, and about from 10 cc's, then we can go up to 20 cc, 30 cc, and then of course 40 cc's. And most of the time the blood sugar is corrected. If you need other things, then you have to do that. Initial prevention of hypoglycemia is the use of intravenous glucose and intravenous protein and lipids. So all these 3 things will help you to.
Right, sir. Another question is, what are the basic first line investigation for neonatal hypoglycemia?
Yeah, first of all, you have to check the insulin level, and also you have to check the there's another level it was mentioned, insulin ratio and glucose. And then there's another one, maybe if Dr. Khalid is there, can you help me?
Sir, actually, Dr. Khalid is on with us via YouTube online.
No,
Due to some
okay.
problem in the link, joining the link, so he's with us, but via YouTube.
Oh, maybe you can ask him.
Right, sir.
I think I mentioned those values in the beginning of the what other
Yeah.
tests you could do. Huh?
Right, sir. So another
Okay.
question is, what is optimal time to screen for neonatal hyperinsulinemia? Some units do not screen until the first week of life, as it is transition period.
No, I think if the levels of you cannot control the blood sugar levels, and then probably you have to think it may be due to persistent hypoglycemia and hyperinsulinemia, and then you can, if you put those things together and do the other tests together, and then you can make the diagnosis.
Right, sir. Another question
And
is,
then they use start the diazoxide and other octreotides. And of
Right.
course, if it does not get better, then what should you do? You have to do pancreatectomy.
Right, sir. So another question is, critical sample indication.
What was that? Hello?
जी sir, आपको आवाज आ रही है sir? Can you hear me, sir?
No. Could you repeat again one more time?
Yes, sir. So question is critical sample indication.
Now, critical sample?
Indication.
Yeah, that is, when you cannot control the glucose with regular methods and oral feeding, then you have to do that. You have to measure the glucose and insulin. I think in the original slides, I did say that what are the other tests you should do. Okay.
Right, sir. I think the questions are, I hope if anyone have questions.
Thank you so much for asking me these questions. It gives me the opportunity to read more on this topic. So I have to go back and read it again. So I have this preparation was done many years ago. So I need to maybe update it.
Right, sir. Sir, Dr. Naveed